Thank you for joining us. I'll start by acknowledging that we are hosting this webinar from Aboriginal and Torres Strait Islander land. Sovereignty hasn't been ceded. I'm joining today from Wurundjeri country. My respects to elders past and present. I extend my respect to all of the Aboriginal and Torres Strait Islander people joining this webinar or watching the recording. Today, we meet to discuss our responses to the Senate inquiry into universal access to reproductive health. First, some housekeeping. We have two interpreters with us, Therese and David. Thank you for joining us today. For all of you watching along, if you haven't already started drafting your submission, we've developed a submission template for you. The link to the template will be dropped in the chat so you can download it. It will download in a Microsoft Word format with very clear fields that you can fill out as we go. The event is being live streamed and recorded, and we'll send you a link to the recording afterwards. Speakers will be visible, but not participants. All participants are welcome to use the chat, though I won't be monitoring it closely, so I encourage all of you to have some sidebar conversations with each other. Please do share resources, links and thoughts that could be useful to each other along the way. We've got the wonderful Patria and Guyan moderating today. They'll be dropping some links in the chat and they'll share our community guidelines for the event. Now they have the power to remove anyone from the webinar who's not following those guidelines. The event hashtag today is abortion equity. So please do get tweeting or Instagramming or Facebooking or whatever platform brings you joy. We've invited an incredible string of speakers who each believe in universal access, but they each bring very different lenses and suggest very different solutions. We'll wind together through the inquiry terms of reference, though we won't read out the terms of reference explicitly because you should have it in front of you in the template. Even if you have varied perspectives to the speakers, write down what your ideas and solutions are. They might include anecdotes from your practice or articles that you recall reading in the past. Everything is relevant. And the idea is, if you can take notes as we go, by the end of this webinar, you'll have your submission drafted. Submissions are due on the 15th of December, so you've got a bit of time to finish it off. And there's some further details and links in that submission template. So I'd like to begin with our first speaker, Dr. Regina Torres Quiazon, Acting Executive Director at the Multicultural Centre for Women's Health, and she is going to define universal access.
Thanks, Bonnie. I'd like to acknowledge that I'm speaking to you from the unceded lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past and present. Thank you, MSI, for holding this event and giving the Multicultural Centre for Women's Health the opportunity to define universal access. And it just occurred to me today when I was reading through my 5 minutes that really the acknowledgement of two countries seems somehow a really fitting segue to this topic. Simply because in order to move towards universal access, all people living in Australia, including First Nations people and all non-Indigenous people who have settled here through the forces of colonisation and migration, irrespective of country of birth, nationality, citizenship, length of residency or visa category, all must be considered and included in our definition. All people living in Australia also includes people who don't have or can't have access to the National Medicare scheme. Now, the Multicultural Centre's work over the last 44 years with migrant and refugee women has clearly shown that legal nationality or Australian citizenship, length of residency and visa category are often the unstated prerequisites for accessing health services. So to put that another way, while it should be felt fairly well known that English language proficiency, health literacy and socioeconomic factors, as we all know, all play a part in people's ability to access health, those on particular visa categories face multiple barriers to accessing information, treatment and services based on their residency status. So many migrants spend years working precariously in Australia, often moving from one bridging visa to another, I think the average time really is 10 years before gaining that permanent residency and really before gaining the full ability to access health rights. For example, temporary visa holders who don't have access to Medicare face restrictions and challenges when accessing contraceptives and reproductive health care due to various factors, including being subject to, restrictive waiting periods and really exorbitant upfront costs. A very clear case in point, in which we've conducted quite a bit of advocacy on and continue to do so, is on behalf of international students or partners of international students who don't have access to pregnancy-related care if they fall pregnant within the first 12 months of migration. Now, pregnancy-related care has been defined by those Medicare items pertaining to pregnancy, including childbirth, antenatal, other outpatient pregnancy-related services, and other gynecological items. Throughout the years, we've received many calls to support distressed students without the necessary healthcare and support, and who are therefore exposed to a whole range of health risks because they didn't meet the 12-month waiting period. Now, this restriction has been a long-standing clause of the Overseas Student Health Cover Deed, which is a deed. The agreement is between the Commonwealth Department of Health and insurance providers who choose to sign on to that deed. And now that particular deed sets out the conditions with which registered health funds have to comply in order to provide insurance products and policies. And there is no requirement or incentive to waive these waiting periods. Now, this is just one, of the many, I'll call them fine print issues to consider in relation to responding to the needs of those made most vulnerable by our current systems. So when writing up your submissions, I urge each of you to focus on the many ways colonisation, racism, xenophobia, homophobia, ableism, and other types of discrimination and structural forces intersect and prevent universal access. Now, how can we ensure that this inclusive concept of universal access translates to inclusive and equitable policy? We have three key asks that directly relate to this concept in two key areas of reference. So firstly, in relation to cost and accessibility, number one is to extend Medicare to include all migrants, irrespective of visa category. Now, in effect, this can abolish waiting and residency periods to health access, especially those directly linked to visa status, and including those contained in the Overseas Student Health Cover Deed, and access to other forms of income support, as outlined, for example, in the newly arrived residents waiting period. How can we do this? Well, we suggest moving away from free market and neoliberal approaches in our migration program and our health services delivery. For example, there are already billions of dollars spent on private health insurance rebates, which could be allocated to fund equitable forms of public health. Saying too, the prohibitive costs relating to visa processing fees, English language entry requirements, and, the recognition of overseas qualifications, which all new migrants must shoulder. So extending Medicare in this way should not be regarded as a radical or innovative solution, but should be seen as a necessary requirement for universal access for all people living in Australia. Universal access and universal health coverage are really, for us, two sides of the universal access coin. So along with that number one ask, we have two other asks in relation to workforce development and best practice approaches. Number two is to include migrant refugee health as a key priority in regional organisational activity and planning. And this includes collecting information about migrant and refugee groups, including residency status, women's preferred language, requirements for an interpreter of a bilingual worker, and collaborating with migrant organisations with the expertise and knowledge in this field. And number three, we should provide ongoing investment to support and develop a bilingual, bicultural health workforce that's professionally recognised and appropriately remunerated. The health workforce needs to represent, reflect and respond to the needs of our current and growing multicultural Australian population. So thank you for your time and for considering these points, and I look forward to hearing from other speakers. Thank you.
Thanks, Regina. It's such an important point when we talk about universal access, because the holistic nature isn't always recognised in policy and in the conversations we have around that. Next, I'm going to introduce Jamal Hakim, who's the Managing Director at MSI Australia and MS Health. Thanks, Jamal.
Thanks, Bonney. Hi, everyone. I'd like to first acknowledge that I'm joining you from Wurundjeri country. Sovereignty has not been ceded, and I'd like to pay our respects to elders past and present, and acknowledge the Aboriginal and Torres Strait Islander people that are joining us today. In Australia, colonial violence resulted in thousands of years of sexual and reproductive health and healing knowledge to be overlooked and prohibited. To ensure cultural safety, we must build a future where we enable self-determination for all, to make decisions over our own sexual and reproductive lives. We've called this webinar in an attempt to bring people together. Our health system needs to evolve, and every one of us here has a role in that evolution. For the first time in history, Australia has committed to universal access to abortion with bipartisan support. There is a goal to implement this by 2030, which is only 7.5 years away, by the way. It is widely acknowledged that sexual and reproductive health inequity, particularly in regional and remote areas, is at crisis point. This inquiry gives us the opportunity to shift from talking about barriers to proposing solutions. So during the Senate inquiry process, we also expect to see thousands of anti-choice submissions, with a wide range of public discourse during hearings that uses language that patronizes, belittles, and judges people for making a very personal choice. We have to combat this sentiment. We have to come together and we speak with a shared voice. So we need one clear message, which is universal access to sexual and reproductive healthcare. Every single person in Australia should be able to get to a service that they want and they need when it comes to abortion and contraception, wherever they may be, whether they're in Hobart to Broome, from Albany to the Torres Strait, or right here in Melbourne. The government needs to fund the gap in abortion and contraception services to remove the out-of-pocket costs. Universal access to contraception and abortion is preventative health. It has significant mental, physical, and cultural health benefits. It supports people to plan their lives, and it creates the space a family needs to avoid risk of poverty. It has huge impacts on gender equity and workforce participation. It improves overall economic output and strengthens the economy. As we go through the current economic climate, pressure is mounting. The increase in cost of living, work pressures, and trauma related to the COVID-19 pandemic will be felt for decades to come. So having universal contraception and abortion access enables reproductive autonomy. It reduces one area of burden for individuals and families to plan their future. At MSI Australia, we have almost 300 staff and 100 doctors who are providers of quality and safe abortion and contraception care, many of who are listening to this webinar or the recording. I encourage all of you to make individual submissions alongside organizational submissions. If you're on board, if you're on committees, if you're parts of communities of practice, you can also support them to make joint submissions. This inquiry must be a showcase of evidence-based conversation. So join us in this public call for universal access to reproductive health. Thank you, everyone.
Thank you, Jamal. Next, we have Dr. Philip Goldstone speaking as the Medical Director at MS Health and MSI Australia.
Thanks, Bonney. For those of you who know me as Medical Director of MSI Australia, I actually hold dual roles. I'm also the Medical Director for MS Health. And we would really encourage your submissions to the Senate inquiry and suggest that they include something along the lines of, we support amendments to the risk management plan and regulatory reforms for medical abortion medications that will improve abortion access and equity. And I'm going to take just a few minutes of your time to explain why this is so important. I commenced my role in 2010, and this was early during our submission process with the Therapeutic Goods Administration for the registration of mifepristone and misoprostol, the medicines that are used for medical abortion. Now, tragically, midway through that initial registration process, we had what is the only death reported in Australia attributed to medical abortion. And this contributed to what was already an extremely cautious approach that the TGA was taking at the time. And it led to the development of a complex risk management plan and some of the additional layers of regulation that exist today. So the risk management plan and other regulation of the medicines used for medical abortion were not sought by MS Health. Rather, they were the result of a protracted negotiation with the TGA with the intent to do exactly what the name suggests, that is, to manage and mitigate risk. The outcome of this process was, however, that Australia became one of the few developed countries at that time to allow prescribing of medical abortion in primary care and the dispensing of the medications through community pharmacies. So it significantly broadened access to medical abortion for people in Australia, and particularly for those living in regional, rural and remote areas. However, we're now 10 years down the track, and in that time, tens of thousands, if not hundreds of thousands of people in Australia have undergone a medical abortion, and the safety and efficacy of medical abortion is now very well established. The risk management plan is now viewed by many as a layer of over-regulation, and MS Health has been working with key stakeholders to review several components that have been deemed to be unnecessary barriers to access. This review is in its final stages of preparation, and it will be submitted to the TGA by the end of November, and we hope that an outcome will be received without too much delay. The revised RMP firstly proposes allowing medical and other healthcare practitioners to become prescribers of medical abortion. So this will remove any restriction by pharma and the TGA on who can prescribe MS2-step and allow states and territories to deem who has the authority to prescribe. Now, this could include nurses, midwives, Aboriginal and Torres Strait Islander healthcare workers. With a potential broadening of the prescriber base, though, the need to certify and complete education where required will remain for now, but we're hoping that the requirement for recertification after 3 years will be removed. But in practical terms, what I hear probably is the greatest barrier has been the requirement for pharmacists to be registered to dispense MS2-step, especially as the registration sits with the individual pharmacist and not the pharmacy. So despite the fact that prescribers have access to an online database of dispensing pharmacists, this has been near impossible to maintain as pharmacists move on or work only certain days of the week. Any of the prescribers amongst us will have experienced the frustration of trying to find a registered pharmacist, and especially those who are providing telehealth services. So the revised RMP proposes removal of the requirement for pharmacists to be registered, meaning that any pharmacist could simply place an order through their local wholesaler, like any other medicine. Now, separate to changes to the RMP, MS Health has other submissions that are already under assessment by the TGA, including updates to the product information, removing the requirement for resource determination, and a change from authority required to streamlined authority. Now, I can hear many of you already asking, why can't the authority be removed altogether? But there is no precedent for any medicine in Australia moving directly from authority required to general PBS. But the move to streamline authority, however, will remove the burden from prescribers to phone authority or log in via Proda to seek authority. And we know that this is really a bugbear with GPs. The current approved indication for use to 63 days has also been challenged as a barrier to access. And this is a more difficult one, and there's a number of considerations here. So the FDA in the USA only in the last few years approved use of the US product Mifeprex to 70 days, but it actually remains the only developed country where a mifepristone product is registered for use at home beyond 63 days. Now, we know that there's widespread use in other countries to 70 days and even up to 84 days, but such use is off-label in those countries as the sponsors haven't sought applications to extend the approved indications. Now, although there's evidence and guidelines to support such off-label use, we know that the TGA is known as a very conservative regulator, and the risk for MS Health of spending hundreds of thousands of dollars on such an application in Australia is not something that we can really justify at this stage, especially as a not-for-profit pharma company. But if anyone out there knows of a donor happy to fund such an application, we'll happily accept those details. So I hope these few minutes have given you a clearer understanding of the current situation. And again, I remind you that when writing your submissions, please include something along the lines of, we support amendments to the risk management plan and regulatory reforms for medical abortion medications that will improve abortion access and equity. Thank you.
Thank you, Philip. Now today we've invited Adam Perry from MS Health to be on hand for any questions. So you're welcome to drop questions in the chat about medical abortion for Adam to answer. Thanks, Adam. And he'll either answer them now in the chat with you all, or he'll take them on notice. Now we were going to have Amy Remeikis speaking today. Unfortunately, she's an apology because she had a personal matter she needed to attend to, but she is going to record her speech for us, and we will share it with you all at the later date when we share all the recordings together. So apologies from Amy, and we'll look forward to hearing her words another time. Next, I'm introducing Dr. Syahir Soffi. Syahir, they, them, is a sexual and reproductive health doctor who lives and works on Larrakia country in Darwin. They're a passionate advocate for trauma-informed abortion healthcare and is a proceduralist providing first and second trimester surgical abortions and feticide procedures for second and third trimester in hospital medical abortions. Thank you.
So good afternoon, everyone. I firstly like to acknowledge that the Larrakia people are the traditional custodians from the land on which I am speaking today, and I pay my respects to their elders, past, present, and emerging. Today, I encourage you to submit recommendations that publicly funded services.
I might just say, Syahir, your sound's a little bit fuzzy. It might have something over the microphone.
Sorry, can you hear me better now?
Yes. You try again.
Can you hear me now? Sorry.
Can I check with someone else? Anna? It's fuzzy.
Sorry.
That's okay. We might
Maybe
go to the next speaker. Come back to you. Is that okay?
Yeah.
All right, and I'll have it. So to build up even more anticipation for Syahir's speech, which is amazing because I've seen it, spoiler alert, we're just going to go to our next speaker, Dr. Catriona Melville, who's the Deputy Medical Director at MSI Australia. Thanks, Catriona.
Good afternoon, everybody. Can you hear me? Thank you for inviting me to speak. And I'd like to acknowledge that I'm speaking to you from the land of the Turrbal people and pay my respects to elders past, present, and extend that respect to Aboriginal and Torres Strait Islander peoples here today. So some of our other speakers so far have summarised some of the key issues facing people endeavouring to have reproductive autonomy in Australia. And I'd like to outline in the next few minutes what I see as the key challenges and my wish list of solutions. So to begin with contraception, in order to improve access, we need to extend PBS coverage to include methods such as the progesterone-only pill, which inhibits ovulation. Now, this is the only reliable oral alternative for people who can't use the combined oral contraceptive pill. And currently, the only available option in Australia is not listed on the PBS, and the cost precludes its use in many people. The PBS should also subsidise the combined vaginal ring to increase access to choice of contraceptive methods. We need to streamline the TGA approval processes for new contraceptive methods. This will enable our population to have access to methods such as the self-injectable progesterone or the combined contraceptive patch, which are available in other wealthy countries such as the UK and US and have actually been available there for many years. As we know, LARC methods are the most efficacious choices for contraception. So we need to ensure there are affordable options for accessing these. The current MBS rebates for primary care are not sufficient for these procedures, so these need to be increased to reflect this and to ensure our population can access these services without paying a gap. In Scotland, as you can probably hear is where I'm from, people do not require a referral to attend a sexual and reproductive health specialist service. Self-referral to specific specialist services, such as those providing abortion care and complex contraception, would reduce the burden on primary care, reduce costs, and streamline access for clients. It already happens with the public sexual health clinics, so I would ask that this can be extended to sexual and reproductive health specialist provided services. So moving on to abortion, I was the lead for my public abortion service in Scotland, where all abortion is free to all people who request it, as is all contraception. So this is possible within the public health system. However, we need policymakers to consider the following. Abortion laws across Australia should be harmonised to create a level playing field and transparency for clinicians and consumers of reproductive health care. Abortion care should be considered as part of a person's reproductive lifespan, given at least 1 in 4 people will undergo an abortion in their lifetime, making it likely the most common gynecological procedure in Australia. Medical abortion provision should be increased as this model of care is accessible, affordable, acceptable and safe, and can be delivered by a range of healthcare practitioners. And I'm sure Lydia will mention some more about multidisciplinary teams. In order to do this, though, we need to start with mandatory inclusion of sexual and reproductive health education in undergraduate degrees and postgraduate training programs, including medicine, midwifery, nursing, general practice, and obstetrics and gynecology. Non-GP specialists also need medical abortion skills, as collaboration between primary and secondary care is essential to allow a seamless journey for a pregnant person. So take, for example, the person who attends an early pregnancy assessment clinic with a threatened miscarriage, but then they disclose they want to terminate the pregnancy. This should be facilitated within that department and hospital rather than send the person back to find a GP who may be able to provide this service or may not. This creates barriers and delays essential care. So it's critical we do not silo abortion care and we ensure collaboration exists between primary and secondary care settings. Surgical abortion must always be retained as a choice and also a necessity for people who aren't suitable for a medical abortion. Lack of abortion services in many public hospitals means that trainees can't access surgical abortion training. Abortion provision for all indications, not just fetal anomaly, must be available in all public hospitals, ideally as a dedicated reproductive health service delivered by skilled professionals as part of a multidisciplinary team. All public hospitals that provide maternity and gynae care have the skills to deliver second trimester medical abortion care, even if they don't have the surgical skill set within their staffing, because this is really no different in caring from someone with a second trimester miscarriage, which these services commonly provide care for. So in summary, I'd like to see access to a more comprehensive choice of effective contraceptive options in Australia by increasing PBS access, streamlining TGA approval processes, and increasing MBS rebates for LARC provision. I'd also like to see abortion care delivered free at the point of care, via self-referral and by a range of healthcare professionals and in a range of settings with clear pathways for all Australians who request this. And absolutely, this must include our rural and remote people and those without Medicare access. Thank you.
Thanks, Catriona. Next, we're going to try Syahir. I can see that you've rejoined. How's your sound now?
Can you hear me?
Beautiful.
Is that better? Perfect. Sorry about that.
Thank you.
Good afternoon again, everyone. I'd first like to acknowledge that the Laraka people are the traditional custodians from the land from where I'm speaking today, and I pay my respects to the elders past, present and emerging. Today, I encourage you to submit recommendations that public funding should be used to provide no-cost abortions in primary care and public hospitals to any pregnant person when requested for any indication at any gestation, with a choice for all available methods. This might sound like a dream, but this is what is already happening in the Northern Territory, where most abortions are accessed at no cost. No-cost early medical abortions can and should be provided in primary care, as this is the most accessible and preferred by pregnant people when it is affordable. In the Northern Territory, Medicare card holders have had access to no-cost early medical abortions since July 2017. And it is now the preferred choice for many, making up almost 3/4 of all abortions performed in the Northern Territory in the first 12 months after this policy's introduction. However, there will always be demand for in-facility abortions, as Catriona mentioned, and this should be available in all public hospitals with obstetrics and gynecology services. Public hospitals already manage miscarriages and stillbirths and abortions in specific circumstances, like when there is a fetal condition. And they already have the staff and resources to then provide abortions for any indication until at least 22 weeks. So why are they still allowed to opt out? If surgical capacity for second trimester surgical abortions are not available, then in-hospital medical abortions can be provided safely and effectively at any gestation. Therefore, availability of in-hospital medical abortion up to 22 weeks should be a minimum standard of care for all hospitals with birthing services. Now, for the less than 1% of abortions that occur after 22 weeks, a feticide service to induce a stillbirth before performing an abortion is usually required. Now, there is a misconception that this can only be performed by subspecialists in maternal fetal medicine, but the truth is the majority of feticide procedures can be performed safely and effectively by proceduralists such as myself who are not subspecialists in maternal fetal medicine. This is very important for access in rural and regional areas, as subspecialists are often based in large urban centres. In the Northern Territory, Royal Darwin Hospital has provided a statewide feticide service since 2018 without an MFM subspecialist. And we haven't had any unsuccessful procedures thus far and no significant complications as well. This capacity to provide feticide has ensured access to no-cost abortion beyond 22 weeks for any indication in the Northern Territory, making it one of the few places in Australia and the world where this is available. Now, it's also important for public hospitals to provide abortions because it is an essential training site for all healthcare workers wanting to work in abortion. But it's not enough to only provide no-cost abortion procedures. Public funding should also cover the cost of travel and accommodation to access abortion when it's not available locally. This is absolutely vital for rural and people living in rural and remote areas who already have to travel for other healthcare due to limited local resources. The funding should also cover any interstate travel for abortion, as some people in Australia still have to travel thousands of kilometres across state borders to access abortions because of the inequitable differences in our abortion laws and service provisions across the states and territories. Abortion access should not be based on people's postcodes, but unfortunately, this is still the case. We're not that different from America. Publicly funded abortion travel assistance should also cover the cost of a support person if this is requested, as this is a trauma-informed and culturally safe way to provide abortion that acknowledges the psychosocial needs of pregnant people. Again, this is something that is already being done in the Northern Territory, and it can be adapted in other jurisdictions. So to wrap up, I just hope I've convinced all of you that access to comprehensive no-cost abortion is possible and should be available to everyone living in Australia.
And I encourage all of you to include in your submissions this recommendation that the Australian government should establish a national task force on abortion access to address abortion equity across all states and territories. Thank you.
Thank you, Syahir. That was amazing. I can see all the exclamation mark comments rolling in on the chat, which you might not see on your phone, but you can catch up with them afterwards. So Syahir, Philip and Catriona have spoken to areas sort of A to C and D, and in a sort of a meshed way of the terms of reference. And I feel like we could spend 8 hours on those sort of 3 and 4 areas, but we're going to move on. And next up, we're going to have Dr. Lydia Mainey, who's going to speak to areas B to D. So Lydia,
I take it away?
Yeah, sure, unless you want me to read your bio, but you can just go for it.
I'll just go for it.
Go.
Thanks, Bonney. Like me, my pitch will be short and punchy. As Dr. Catriona Melville foreshadowed, the focus of my presentation is predominantly the nursing and midwifery sector. My 3 key requests for the inquiry are as follows. 1, a royal commission into the health and wellbeing of the Australian health workforce. Providing equitable reproductive health care relies on a stable and committed workforce. However, current under-resourced fragmented services which perpetuate inequitable care and heightened risk to patient safety is causing a vicious cycle where workers become mentally and physically exhausted. This compromises their ability to provide good care. Many are leaving their professions. We need to address this urgently and comprehensively. 2A, standardised evidence-based reproductive health training across all pre-registration nursing and midwifery courses. This should be implemented and overseen by the Australian Nursing and Midwifery Accreditation Council. 2B, postgraduate education pathways to upskill the current workforce these should be accredited by reproductive health peak bodies. Nurses and midwives are the largest part of the health workforce. Moreover, they are more likely to be the stable workforce in rural, remote, and very remote communities. It is time to stop pontificating over whether they are the best people to provide abortion care. The scientific evidence is overwhelming. Adequately prepared nurses and midwives are as safe as doctors at providing medical and surgical abortion care. 3, reducing the TGA's risk profile of RU486, mifepristone, to allow nurse practitioners and certified midwife prescriptions. The high-risk profile results from cloak and dagger politics and is unnecessary. It does not stand up to the standards of a civilised secular society. Finally, a call to action. As the largest workforces in Australia, nurses and midwives have a significant political leverage. I call upon our peak bodies, unions, as well as vocational and higher education communities to submit to the inquiry. Thank you.
Thank you, Lydia. Cloak and dagger politics, nice quote. Thanks for jumping in there with some solutions. I can see people in the chat asking for lists of recommendations coming up with today, which Anna's committed to getting through by the end of this week, which is bold, and that sounds good. I think I'd also like to encourage you all to come up with your own solutions as part of this, or how you might build on them with your own experience or put your own words to it in different ways. Because I think it's that thing about, for lots of these things, there's no easy answers, and it's our collective brains trust and not just the speakers you're seeing today that will come up with the solutions. So thank you. So next we have Swathy Santhakumar, to be doctor, speaking to area C of the terms of reference. Swathy is a first-year medical student in Australia. She completed her honours research in 2020 looking at the coverage of abortion care content in medical schools across Australia. She's worked in this healthcare space for over 4 years in different capacities and wants to encourage more young people to engage in improving healthcare access and delivery. Thanks, Swathy.
Hi, everyone. I will just say before I begin, I am recovering from a cough, so apologies if I need to mute myself briefly. But I'd like to start by acknowledging the traditional owners of the land on which I'm joining from, the Turrbal and Yagara people, and pay my respect to elders past, present, and emerging. To increase access to abortion care, we need to bolster our future healthcare workforce. We need to reshape medical degrees. Empowering students to take an interest in sexual and reproductive health shouldn't begin after medical school. I'm at the end of my first year in medical school, and what I found is that whilst many of us come in with preconceived notions about specialties we want to go into, most of us are impressionable, open to trying other areas to see if we connect with them. We want to learn how to become the best doctors we can be. So we need opportunities to experience different areas of medicine through lectures with experts in the areas and options to complete work experience in clinics with experienced abortion providers. We already know that abortion education, much like abortion provision, is a lottery. The amount of exposure you get is dependent on your university, on the people writing your curriculum, and on the hospitals that you complete your placements in. Even if you're placed at a hospital which provides abortions, there's no guarantee that you'll be involved in any part of the process of one if you wish to. This means that junior doctors are going out into the workforce with really patchy knowledge, if any, about abortion provision. Even if we don't end up becoming abortion providers ourselves, we have an obligation to patients who seek out this procedure. We need to be informed about pregnancy options so that we can pass on this information to our future patients and ensure that they're fully informed and get the care they need, even if we're not the ones directly providing it. The future healthcare workforce needs to be equipped to provide universal access. To do this, we need to make some changes to how we engage with medical students. In the context of universal access to abortion, my 3 asks are: number 1, abortion education needs to be a mandatory part of every Australian medical school's curriculum. This includes for people who don't want to become abortion providers themselves, but who need to understand that information to correctly advise future patients of their pregnancy options and to be able to refer on to abortion providers. Number 2, the government needs to invest in abortion education, such as additional training facilities and the facilitation of partnerships with community providers to allow students to really immerse themselves in the field and speak to sexual and reproductive healthcare experts. This would really give medical students much needed clinical exposure. And number 3, we need investment in clinical guidelines and medical publications that normalize abortion and reduce abortion stigma. Abortion is healthcare, yet abortion is often framed in medical degrees as an ethical issue. Framing it like this takes away from the fact that abortion is written into health law, and it needs to be introduced from a medical context instead of an ethical one. Greater access to clinical guidelines and other medical texts will help medical schools normalise abortion care within healthcare. All of these asks could also be beneficial for people training as nurses, midwives, and Aboriginal Torres Strait Islander healthcare workers. My relatively short time at medical school has shown me just how capable and excited medical students are to become doctors. Many of us are keen to provide sexual and reproductive health, but any opportunity to train for us is much further down the road. In a healthcare workforce crisis, it's time to invest in pre-service medical education so that we can provide abortion care after we graduate from our degrees. Thank you, everyone.
Thank you, Swathy. And what great timing to follow on from your ethics exam, where we had a conversation beforehand and you were saying a great deal of the questions were focused on abortion. So great time to participate in the system and then smash it afterwards. Next up, we have Delaram Ansari from the Multicultural Centre for Women's Health, where she works as a research advocacy and policy officer. Thank you.
Thanks, Bonney. Hi, everybody. Before I begin, similar to last speakers, I would also like to acknowledge that I'm joining you from unceded sovereign lands of Wurundjeri people of Kulin Nations, and I pay my respects to elders past and present, and wish to extend that respect to any Aboriginal people who are joining us here today on this call. So in my discussion of the 2 points, I'm focusing on unpacking the intersectional approach necessary to achieve health equity and abortion equity. Point D specifically is about best practice approaches to sexual and reproductive health care. Now, best practice approach to an equitable abortion care is one that is culturally responsive. And what we mean by that is that culturally responsive service delivery is bigger than one's ability to be able to interact with people from different backgrounds and cultures. And it's really about removing all barriers to accessing healthcare and abortion. As you may know and you have heard, these barriers include things like lack of information provided in languages other than English, unaffordable costs of healthcare, restriction on visas and residency conditions, stigma and discriminations both within and imposed on communities, and also a lack of culturally appropriate service provision. The case Regina mentioned earlier about international students not being entitled to Medicare is an example of how migration-related policies particularly impact sexual and reproductive choice and also access to abortion care. Considering this itself, and also the fact that how migrant and refugee people's sexual and reproductive health is very much influenced by intersecting social, political, and economic factors, I really want to urge everyone to make sure your submissions advocate for removal of structural barriers that prevent access to care. When we look at point E, which was about sexual and reproductive health literacy, as you all know, I'm sure, health literacy is super important. But whilst providing in-language resources and culturally appropriate service provision is crucial, we also need to ask and make sure migrant and refugee women and people can navigate the health system itself. We need to ask, do they feel safe accessing these services? Are they informed and feeling empowered to make choices for their health without judgment or a stigma? If the answer to any of the questions I've asked is a no, then we are not adequately advocating for this concept of health literacy. Everyone has a role to play, whether you are a health provider, a researcher, or a policymaker. We would really like to encourage you to make a submission because there are actions you can take to improve migrant and refugee women's health today. I encourage you to think about what equity means. We cannot be equitable without using an intersectional lens and advocating to remove barriers to access. When we are talking about equity, we also really need to make sure we are reaching those who have been made even more marginalized by our systems. That can be migrants who are also part of LGBTI community. It can be migrant and refugee women with disabilities or migrants with low income. On that note, we have 4 specific asks for you to include in your submissions. Number 1, advocate for targeted and sustainable funding for migrant and refugee women's health programs, including healthcare provision and access to abortion care. Migrant and refugee women are mentioned as a key priority group, yet there is no targeted sustainable funding for migrant and refugee organizations. And according to Census 2021, just last year, over 51.5% of Australia's population are migrant and refugee people. Over 51% is not a minority group. So it's time for our government to provide targeted and sustainable funding. Number 2, we need primary care and prevention to work in collaboration with each other. For example, we need to improve referral pathways between clinical care and health education for migrant and refugee women and people. Number 3, we need to advocate for upskilling, resourcing, and embedding bilingual workers across sexual and reproductive healthcare services. And number 4, we have to bring culturally appropriate sexual and reproductive healthcare into mainstream programs by collaborating with migrant women's organizations to develop best practice guidelines for culturally responsive service delivery. Now, MCWH has led numerous programs and initiatives that have been really successful in promoting health equity for migrant and refugee women and their communities. I encourage you to read about them on our website, and please do reach out if you would like to know about them or discuss them further. Today, we are given a unique opportunity to advance health equity in Australia, and every submission counts. Thanks for listening, and all the best with your submissions.
Thank you so much, Delaram. So I think so much of that would be about advocating for increased investment in migrant refugee women's run health services to be leading programs around these sort of initiatives. Yeah, thank you. So next I'm going to introduce Margarita Dalocco Vaccaro. Margarita is a migrant queer young woman with disability. She currently works in youth development at Women with Disabilities Australia. Thank you, Margarita.
Thank you. I want to first acknowledge that I'm calling in from the land of the Ngunnawal Ngambri people, and I pay my respects to elders past, present, and emerging. I also want to acknowledge the importance of including and involving First Nations voices in any and all conversations about reproductive health. I also want to give a quick description of myself. I'm a white young woman with brown hair that is tied up. I'm wearing a lime green short sleeve and collared shirt. My background is blurred. It's important to acknowledge how disabled women are thoroughly impacted through conversations around reproductive rights and abortion laws, and how in so many of these conversations, we lack a solutions focus. Conversations are beneficial when they lead to action and response, which is what we're calling for today. When talking about the road to abortion equity and reproductive health, talking about reproductive violence against people with disability is fundamental. There are a few main actions that we call on to be enacted. Firstly, a plan to conduct a legislative scan across all Australia to harmonise and update legislation across jurisdictions on reproductive rights. Currently, different states and territories have different legislation on reproductive rights with varying access levels. Not only is this mix of legislation harmful to women and gender diverse people, but is confusing and makes accessing services difficult and daunting. Without having harmonised legislation, women around Australia are unable to access the same care, rights, or education. Not only is it essential to ensure women, especially those with disability, are not coerced or forced into using contraception or going through sterilisation, but it is one of Australia's commitments under CEDAW that we must commit to. Secondly, we need to commission a national inquiry into reproductive violence for people with disabilities, starting with the removal of babies and children from parents with disabilities and forced sterilisation. Women and gender diverse people with disability have been subject to reproductive violence and coercion, much of which has gone unnoticed. This requires a national inquiry, not only to understand and uncover these practices, but to ensure that women and gender diverse people do not continue to be subjected to this violence. Aboriginal and Torres Strait Islander people have to be at the forefront of this conversation, with a long colonial history of child removal that continues to traumatize families as women with disabilities are separated from their children even now. Thirdly, the government needs to implement a national redress scheme for victim survivors of various forms of sexual and reproductive violence, which is inclusive of and addresses both Aboriginal and Torres Strait Islander women and other communities of disabled women who have intersecting and overlapping identities. This redress scheme needs to include specific measures for victim survivors that range from compensation, access to rehabilitation, and trauma, recovering to apologies, memorialization, and community education. Lastly, we need a national strategy in consultation with people with disability and their organizations to improve access and availability of comprehensive and disability inclusive sexual and reproductive health and information, particularly for young women and girls. Recently, a Women with Disabilities Australia report uncovered that most young women and girls don't make their own decisions on menstruation and contraception, instead parents, guardians, and doctors making these decisions on their behalf. Without a strategy to improve education and knowledge, young women are left without knowing their reproductive rights and what they're entitled to, leading to an increased risk of trauma, coercion, and force. These are all important and highlighted actions that needs to be taken to achieve reproductive justice. Thank you.
Thank you, Margarita. And if you haven't seen it already, Women with Disabilities Australia published a report on sexual reproductive rights yesterday. So we'll drop that link in the chat and you'll be able to reference it in your submissions. Next, we have Morgan Carpenter. Morgan's going to speak to Area G and perhaps things around that. Morgan is an intersex man, bioethicist, executive director of Intersex Human Rights Australia, and the creator of the intersex flag. Thanks, Morgan.
Thank you, Bonney. It's great to be here. People with innate variations of sex characteristics use a variety of different terms to describe ourselves, including the word intersex, clinical diagnostic terms, and terms like differences of sex development. We're a diverse population with diverse identities and self-understandings, which problematizes popular misconceptions like the idea that we all share an identity. And indeed, misconceptions and stigma play a significant role in determining the way we're treated, socially and medically, and including in relation to sexual and reproductive health. So what are these issues? Our reproductive capacity is frequently disregarded and even eliminated in medical interventions intended to make our appearance and function fit medical norms for female or male bodies. And these often take place before we have age and agency to express our own values and preferences. And our access to reproductive services then is impeded, and our lives even are frequently not seen as worth living. So I encourage you to make submissions that support our right to bodily autonomy. And for some people, including me, we've never been understood to be fertile. For other people, reproductive tissues are routinely removed, often on the basis of gender stereotypes and without clear evidence. In 2016, a family court, a judge, adjudicated a case that's remarkable, not for its decision, but for the way that it made clinical reasoning transparent outside of medicine. The judge described how a preschool child born in 2010 had already been subjected to surgeries that had, quote, enhanced the appearance of her female genitalia. The child had 17-beta-hydroxysteroid dehydrogenase 3 deficiency, or 17-beta-HSD3, what the judge termed a sexual development disorder. The case was taken to authorize her sterilization, which the judge approved. In justifying this, the judge relied upon a medical paper that called for the gonads of children with this trait to be monitored, not removed. The judge relied on gender stereotypes about clothing, toys, and colors to support the sterilization. And indeed, analysis of literature from the World Health Organization and elsewhere shows that sterilization of children with this trait is now associated with female sex assignment and not male assignment. A clinical submission to the Senate in 2013 suggested that children with a different trait, complete angioinsensitivity syndrome, were no longer subjected to early sterilizations because historical claims about high rates of gonadal cancers were then understood to be wrong. But evidence from a 2019 conference presentation by a pediatric and adolescent gynecology clinic shows that all children with these and similar traits seen by that clinic have been subjected to sterilizing surgeries. Many, possibly all children diagnosed early were also subjected to early genital surgeries. So the future capacities of children with intersex variations to make decisions in line with their own values, interests, and preferences for genital appearance and function are being systematically disregarded and impaired. Additionally, people with sex chromosome variations can face a range of health issues, including impaired fertility. While access to reproductive services has been improved for women and men with viable sperm in ejaculate, access to surgical procedures to retrieve viable sperm remains inaccessible to many men. And I want to just talk about genetic selection. So genetic analysis that has provided the evidence to reduce gonadal tumor risk rates associated with partial androgen sensitivity also remark on the value of genetic research into the origins of intersex traits for, quote, reproductive planning of the family. The same World Health Organization information that calls for the sterilization of female-assigned children with 17-beta-HSD3 also remarks on the availability of prenatal diagnosis for kindred of affected patients. And data on terminations from a range of countries shows high rates of terminations of fetuses with sex chromosome variations. This situation is disproportionate to the impact of such traits on people's lives. It's at odds with evidence showing that people with innate variations of such characteristics are capable of living happy and fulfilling lives. So societal issues such as body shaming and ideas about how bodies should look and function play a key role in determining how we are treated and even if we're born in the first place. Just as sex selection is a cause for concern for women, so selection on the basis of sex characteristics is a concern for the intersex movement. In general, infertility is a huge problem for our community. To a significant degree, it's a problem for many of us because of the way we've been treated by medicine. And whether infertility or impaired fertility are iatrogenic or inherent, all of us deserve the right to access reproductive and sexual health services free of shame and stigma. We need support for specific attention to our health and human rights concerns. Our call for action and a 2021 Australian Human Rights Commission report provide recommendations for better practice, including legal protections, resourcing for independent psychosocial support, rights-affirming guidelines, education to address stigma, and community-led research. Thank you.
Thanks so much, Morgan. We met your dog in the background too while you were talking. What's your dog's name?
Thanks. Her name's Kiva. I didn't see her at all. I had two files on my screen that I was trying to refer to. Thank you for your attention today. I really appreciate it.
It's a really
I hope you will all make submissions that call for respect for our bodily autonomy. Thank you.
Thank you. It's a really important part of the conversation, and particularly when we talk about rights and universal access of in the intersex context, it's around so much various legislative reform and similar in terms of people with disabilities and the complexities between jurisdictions and how much needs to change requires a scorecard bigger than anything we could produce, but is something that we can fit within this inquiry and is something that we can hold the National Men's Health Strategy 2 and the National Women's Health Strategy 2, and the Preventative Health Strategy, if you feel like pulling out a third one. In terms of those trifecta of policies is what will make universal access possible in the next 7 years. So next we have Dr. Ruth McNair, AM, who's also speaking to Area G. Ruth, she is an honorary associate professor at the Department of General Practice, University of Melbourne, and she's a general practitioner at an inner city Melbourne general practice. Thank you, Ruth.
Thanks, Bonney. And I'd also acknowledge that I'm on Wurundjeri land, the people of the Kulin Nation. I also wanted to acknowledge the speakers today. Most of you, or I think all of you, are using a very inclusive language around gender by using words such as women and other people, or women and people. So I think that speaks a lot for the level of the speakers today and their inclusion. So I'm talking to trans and gender diverse non-binary people. Firstly, they tended to have been overlooked in sexual and reproductive health care, partly because they haven't been very visible. But I think at this point in Australian life and social advances, trans and gender diverse and non-binary people are increasingly seeking out reproductive health care and sexual health care that's more appropriate. You know, many trans people I'm seeing in my practice seeking contraceptive advice, they're seeking out abortion services at times, and pregnancy care where possible. So these issues are really top priority for many trans, non-binary and gender diverse people. Also, fertility preservation is another big area that's growing with more young people seeking out affirming, gender affirming care such as hormones or surgical treatments. So what's the issue around the inquiry? Well, I think it really relates to barriers. This group have enormous barriers to accessing healthcare, and particularly sexual and reproductive healthcare. One of the big ones is related to economic disadvantage. Trans, non-binary and trans and gender diverse people are much more likely to be in the lower socioeconomic bands in Australia, and that relates to long histories of abuse and violence, of family violence sometimes, of difficulty accessing education both through school and higher degree areas, and the TAFE system. So this all points to high levels of discrimination, and that's a huge issue around economic instability. Many trans and non-binary people lose work during their gender affirmation journey, which also adds to this economic burden. So one of the key points around trans and gender diverse access is enabling publicly funded services, first and foremost. Secondly, barriers relate to fear of discriminatory treatment within healthcare. Many trans, non-binary and gender diverse people have experienced discriminatory care, you know, being turned away from services, whether they be primary, secondary or tertiary, being vilified or abused within services. These are happening today in 2022. They're not historic issues, and people really talk about it frequently in my clinic, that they are worried about this happening again to themselves, or they've heard about it happening to other people. So many trans and gender diverse people don't access the service in the first place. Secondly, and most importantly around access, is poor competency amongst healthcare providers. We really have very little education at this point around trans, gender diverse and non-binary people from medical school up. And I wanted to acknowledge Swathy's research there, and the fact that that's such an important issue for, you know, a wide range of topics within medical education. So, you know, as a medical provider, medical service provider, I've been acutely aware of the lack of education in my training and had to seek it out separately or develop my own training, and that applies to many of us. So one of the key pieces of advice that I would like us to raise in the inquiry is around improving trans and gender diverse and non-binary inclusion in all levels of healthcare education, so that providers feel more competent to understand the needs of this group, feel more able and skilled to have open and adequate communication and really understand where they can provide support. And finally, the elephant in the room is transphobia. There is still a degree of transphobia in the healthcare setting. It's not just about lack of information, it's about literally turning away from this group. And I think this is needing to be called out, and we need to be sure that we are really removing as much transphobia as we can through education and training and through advocacy. That's all I have to say. Thanks so much.
Thanks, Ruth. It's a whole lot of really important points there again. And I think really drawing that connection between movements against like LGBTI inclusion are tied into movements against abortion access, which are tied into movements against gender equity. And it's that way that the collective energy we're trying to bring together today is fighting a really similar anti-choice lobby group that's that organises well. So let's organise ourselves well to combat that in the submission process. So next we have Dr. Romy Listow from Women's Health Matters. So Romy is a Senior Health Promotion Officer at Women's Health Matters in the ACT. She's also a Australian Women's Health Network board member and co-chair of the policy subcommittee. And Romy's going to speak to Area H, reproductive leave, our repro rights at work.
Thanks, Bonney. So I'd like to start by acknowledging First Nations people as owners of the land that we're on today. I'm on the land of the Ngunnawal and Ngambri people and pay respects to their elders past and present, as well as all Aboriginal and Torres Strait Islander people with us today. So the inquiry terms of reference H refers to the availability of reproductive health leave for employees. And I'm really excited to speak today on how we can embed reproductive rights in our workplaces and draw from some work we've done recently at Women's Health Matters on our own reproductive health policy. So reproductive health leave is a paid leave entitlement for employees to balance their reproductive needs, sexual health and well-being. It recognises that the bodies of people with uteruses may experience changes such as menstruation and menopause, which are not illnesses, and require procedures such as abortion, which do not treat illness, and so aren't really suited to sick or personal leave. Depending on how it's implemented, reproductive leave can remedy inequity in access to leave and address factors contributing to the gender pay gap. It also has the potential to revolutionise our workplaces by giving greater social value to reproduction, shifting gendered stereotypes of efficient masculine workers by creating space for flexibility, care and rest, and allowing people with uteruses to be embodied at work. So reproductive health leave in the more limited form of menstruation leave is as old as the 1920s and has been legislated or proposed in the then Soviet Union, across East and Southeast Asia, and more recently across Europe, South America and Africa. In Australia, the availability of reproductive leave is limited, and it's really in the very early days as an idea and entitlement. So this space is currently being led by a handful of organisations and unions who are piloting reproductive leave either as a workplace policy or as a bargaining claim for specific organisations in specific sectors. Some of these include the Victorian Women's Trust, the Health and Community Services Union, Modibody, and ourselves as Women's Health Matters, to name a few. Across these organisations, our policies differ quite a lot in terms of the number of days in the entitlement, ranging from 5 days to 24 days per calendar year, and their scope also differs. Some do have a more limited focus on menstruation, menopause and miscarriage, while policies of HACSU and our own have a much wider reproductive health scope, including leave for abortion, contraception access and fertility treatment. So obviously, we're advocating for this wider reproductive health scope and the explicit inclusion of abortion, both to destigmatise abortion by embedding access in our workplace rights, but also because we know lack of access to paid leave adds to the very high cost of abortion care. Ultimately, we want reproductive health leave to be legislated in the National Employment Standards as a universal protected entitlement. However, as I mentioned, reproductive health leave is really in its early stages here, and so we're probably some way away from that happening. I think it's really important to remember that it has actually taken decades for paid parental leave and domestic and family violence leave to be legislated. So with this inquiry, there's an opportunity to recommend some of the groundwork to build the case and evidence. And in particular, I'd suggest recommending that the Australian government, firstly, commission research into the impact of reproductive health on women's and people with uteruses engagement in the labour force, and to evaluate existing reproductive health leave policies. And secondly, to conduct public consultation around reproductive health leave to establish community interest and support. There are some challenges and risks to implementing reproductive health leave. There is a risk it will reinforce gender inequality and gender essentialism and discourage employers from hiring women and people with uteruses. But this was also a challenge around paid parental leave. And I think what it speaks to is the need for strong political support and a really supportive public discourse. And that's also why we shouldn't and can't rely on this inquiry alone for change. We also need to be guiding the conversation. Like with domestic and family violence leave and paid parental leave, we have a role to play as advocates and workers in negotiating reproductive health policies in our workplaces, in our enterprise bargaining agreements, and within our unions. It's up to us to create the groundswell that will ultimately be needed to bring reproductive rights to the workplace.
Thank you, Romy. That's really beautiful. And I feel like you just answered that point in terms of reference perfectly. So just feel free to be like what Romy said. Next up, we've got on area I, any other matters, the one and only Brenna Bernardino speaking as a reproductive justice advocate. Brenna Bernardino is Timorese, Portuguese and Torres Strait Islander. She has a Bachelor of Arts in Psychology and Spanish from the University of Melbourne, a Master of Public Health from the University of Queensland and a Sex Educator Certificate. She's conducted research in health promotion and Indigenous health in both Australia and the United States, and she's joining us from Texas today.
Thank you, Bonney. Good afternoon all. It's currently midnight here in Texas, so let's do this. I'd like to acknowledge the traditional owners across the lands that we're meeting on today. I'm joining you from the lands of the Acosias, Karankawa, and the Atacapa, also known as Houston, Texas in the USA. I have lived between the US and Australia and am now in Texas, one of the hardest hit states for reproductive freedom in the US. Here, abortion is completely banned with very limited exceptions. As a result of the overturning of Roe v. Wade in the USA, Australia now has the unique opportunity to, as the National Women's Health Strategy says, provide equitable access to abortion. To reimagine new possibilities for reproductive freedom in Australia, we must look beyond reproductive rights alone. Making reproductive choices can be limited by barriers such as cost, location, stigma, and a lack of cultural safety, among other barriers. One answer is reproductive justice. Today, I will drive home the message that universal access is the floor, but fighting for reproductive justice is the ceiling. And to clarify, reproductive justice is not radical or a new idea. It is fundamentally about shifting our perspective and privileging the perspectives of underserved communities. It's about health equity. One definition of reproductive justice came from a wonderful group of Black women in the US, and they say it's the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. When we think about universal access, the abortion equity is central, but it is just the beginning. And when we think about access from a reproductive justice perspective, it includes access to things like comprehensive relationships and sexuality education, contraception for those who want it, support for miscarriages and infertility issues, living free from sexual violence, a living wage, and living in a society where children like Cassius Turvey can live long, healthy, and happy lives. When reproductive justice is achieved, it means that people can make reproductive decisions without social, cultural, economic, and political barriers. So how can you advocate for reproductive justice in your submissions? It's really about an equity lens on every single point you make. With each area you write about, think about the needs of people who are the most negatively, disproportionately impacted by our policies and laws. And my screen has just gone black, so I am going to divert to my phone. First Nations peoples, migrant and refugees, including people on temporary visas, LGBTIQA+ people, people with disability, sex workers, and those who are incarcerated. This means ensuring there are adequate resources for all these people to make reproductive decisions about their bodies and lives. This is how we work towards reproductive justice. A future where everyone can make reproductive decisions could mean an increase in First Nations birthing practices to improve birth outcomes for mums, bubs, and communities, healthcare choices related to fertility and sterilisation that are based on situation and not age. It could also mean the full spectrum of parenting options like adoption, support to be a parent, single parent, culturally safe abortion care, and to provide support to those who are childless or child-free, whether by choice or circumstance. When we reimagine new possibilities, we change the future. It's about control versus freedom. Freedom from influences to control our own decisions, and we need more resources. And we need those resources in the hands of people who need those resources the most. And we need long-term funding, free of restrictions. Universal access is the floor, but fighting for reproductive justice is the ceiling. And when we centre community voices, everyone will benefit, most of all the people who need it the most. I encourage you, if possible, to collaborate on your submissions with other individuals or organisations. This will ensure diverse representation, ideas and voices are included. If you are writing a submission for an organisation, consider who has the power over the content. If you represent disability or LGBTIQA+ organisations, are you including the voices of First Nations or trans people or both? Our starting point begins with funding universal access to abortion because we need abortion equity now. It continues when we make a commitment to continue every day to ensure that there is reproductive justice for all. And that fight, it doesn't end. We just keep pushing the limits of what is possible. Thank you.
Thank you, Brenna. What a lovely way to end our journey through that terms of reference, starting with Regina and ending with Brenna, and bringing it to reproductive justice and how this is a part of conversations throughout communities. We're going to end with a speech from Alyssa Shaw from Fair Agenda, and she's going to be speaking to next steps and about rallying broader community action, because we're a very small component of the voices that need to be heard. And while we'll provide some of the submissions that are informed right in the middle of the sector providing this care, we also need to think about how we engage people in our communities. So Alyssa has held leadership roles across government, private sector and non-for-profit organisations and managed national campaigns and projects, including Raise the Rate, Sheequal and NAIDOC Week. So I'm going to hand over to Alyssa to talk about next steps from here.
Thanks, Bonney, and thanks everyone. It's been so wonderful hearing everyone, and I've certainly learned a lot. I just want to acknowledge that I'm calling in from Bunurong land and also water. I live right next to the beach. I'm very lucky. But I say that also to acknowledge that the doctrine of aqua nullius has not been overturned, and we still need to return water rights to our First Nations people. So my name is Alyssa. I'm from Fair Agenda. We're an independent community campaigning organisation focused on gender equity. We have over 40,000 people that are members from all across Australia. In this space, we've really looked at decriminalisation and safe access zones in the past, but the lens we're bringing to this is really focused on abortion access, and that's the campaign that I run. And we do this through thinking about what's the level of public pressure we need to create for this change. So we know social and cultural change is critical to getting political leaders on side, the people making the decisions. But also, as we've talked about already, it's about eliminating stigma so that we can have universal access and one day universal acceptance that abortion care is healthcare for anyone who needs it. So we see this inquiry as a really crucial stepping stone to getting meaningful action on addressing abortion access. It's a complex area of policy, which I think we've heard very much today, and it's going to require federal, state and territory governments coming to the table to make this possible and to ensure that wherever you are in Australia, you can get access to compassionate abortion care. Everyone has something to contribute to this inquiry, and it's going to be important that everyone does that in order to get the outcomes we need. I've met with a lot of government ministers and MPs, and I've heard in no uncertain terms that we will need public support to get this over the line. So our strategy is around creating a volume and a breadth of supporters in order to do this. Many of us are supportive for change, and Fair Agenda did commission national polling in the middle of this year, which shows that the majority of Australians are with us. 3 in 4 Australians support government taking action to address abortion access. But as we've also heard today, there is some very well-resourced, influential outfits that don't agree with us. They've seen Roe versus Wade as an opportunity to wind back abortion rights here in Australia. And it's, I guess it's also worth noting that there are several members in the government itself that don't support abortion rights. So there is resistance. I do need to point that out. This is not a done deal. And it's going to mean that we all have to work together and with the community more broadly to get this over to the line and make the progress that we all want to see. So we have a range of activities planned between now and when the committee delivers its report at the end of March. We really need a loud and breadth of voices coming together, and this is a really great starting point, and it's just so wonderful to be here to connect with everyone. For us, we're going to be starting with an event at the end of the month to launch an abortion access resource. So one of the things that's become really apparent to us speaking to politicians and to our members is that there's a really low level of knowledge around abortion policy in Australia. People think, we've decriminalised it, great, we can all go home, done deal. We all know that's not the case. So what we're trying to do is really translate in a simple way what are the key problems and what are some of the key solutions to addressing abortion access. And a lot of those things go to all the great content and ideas and solutions that people today have talked about, and trying to do our best to condense that in a way that people can understand really quickly. So what we want is a space for the community to come together to look at this resource and to feel empowered and supported to make their own submission. We know that it's going to take a volume of support. It's going to take people with lived experience of abortion as well, writing in and telling the government, you've got to step up and make this change. So we will release this resource. We'll also be using it as a key part of our advocacy across the Parliament, releasing it to media as well. As I said, it's going to articulate key issues and solutions. Some of the recommendations or some of our solutions we hope will be recommendations that people here take on as well as members in the community. The key one is the creation of a national task force, which has already been talked about here. We need to make sure that all those different governments come together and deal with the breadth of issues that we know are on the table that need to be addressed to move us to universal access. We also know, though, that that's going to take time. So we also need immediate solutions to support people to access the information they need to access abortion care now. And we also need the government to step up and fund equitable access to abortion, because we know that affordability is a key issue at the moment. And we've heard about the various cohorts that are particularly impacted by that. So they're going to have to put some dollars there until they can, long-term actually embed this into our public healthcare system. So I would very much ask you to support us and to be part of this community campaign through reflecting some of these solutions as recommendations. We can send that through, I'm sure Murray Stokes will help us facilitate that when the resource is done. Talk about these recommendations. We'll give people opportunity if you like to endorse this resource, so that when we go out to media and to politicians, where there is a collective voice talking about all the things that need to be done. And also you can promote it through your networks to make sure that members of the community that you can reach, that we cannot feel empowered and supported to make submissions. And on that, we'll be using some of our campaigning tech wizardry to create a portal for people to submit individual submissions really easily to the inquiry. That's going to be really important because we know that people, organisations opposing us do that very effectively. So we can expect thousands, if not tens of thousands of submissions from them. So we do need to counter that by volume in some way. We do have a campaign, an ongoing campaign on this, which I can drop in if you want updates and to join the Fair Agenda community. But otherwise, really appreciate the ability to connect with everyone here today and just really encourage you to think about how you can disseminate this to your networks and how you can get community members involved. I'm feeling really optimistic about this opportunity, but it's not a done deal. So we've got to push a little bit more. I know it's the end of the year and everyone's really tired, but hopefully we can make this a really great opportunity that sees the great change we need. Thanks, Bonney.
Thanks so much, Alyssa. Great way to close it off. And that volume of submissions is everything. So I hope you've all got together some individual submissions or organisational ones tonight, and at least you've got a bit of a draft going. Finally, a few points. Thanks to our two interpreters today, Therese and David. There were some really complex medical terms in there and some speedy speaking. So thank you for bearing with us. Thanks to Anna J. Bargay and Diaz and Patria Lee for the work behind the scenes. Thanks to all of you for hanging on until now. Most of you hung on right till the end. So thanks for that. And you'll have the recordings available if you'd like to watch any part again. And with your voice and our collective energy, let's make universal access a reality by 2030. Thank you.